Shilpa wasn't scripted or billed to talk about this, but with our change of programme today, she's kindly agreed to say a few words about what we found in that report. So Shilpa.
Thank you, Chris. Yes, so that is my sense of urgency. There's a call at 8:30 saying Susie and Amanda can't make it. Can you step in at the last minute? And also my sense of hope is that you don't mind that I don't have a presentation as David's just delivered. I am going to talk to you about some work that I did with my colleague Chris Naylor at the King's Fund about quality improvement in mental health. So why did we focus on mental health organisations? So seemingly the adoption of quality improvement at scale doesn't seem to be to the same extent as it does in perhaps different settings like acute care. Is it because, well, what is it about? Is it something about the quality improvement tools, the approaches, the methodology? We're not sure, so we set off to look at 3 examples where quality improvement has been adopted as the routine way of working, and as David put it, improvement is the daily work. So these places are within the NHS. They're East London Foundation Trust, and the Tees Eskin Wear Valleys NHS Foundation Trust. And also we wanted to look at one non-NHS example, so this was the Institute for Mental Health in Singapore. And so I'm just going to run through what we learnt, and no surprises. It was really about how the senior leaders created the conditions to really help quality improvement flourish. As Chris mentioned, it is about the leadership role, and I don't think we can overlook that. And it's an important theme, and so that is what we found. And board level support, and that is the whole board. So it's the executives and the non-executives. They all play a role, and there were, to begin with, in those places, within the board, there were people who were more immediately drawn to the idea of quality improvement, more easily won over. There were some that took a bit more persuasion. They needed some convincing. Some of the arguments were, as David set out in his slides, the objections, the sort of commonly heard things. But what actually helped was really sort of partnering with others, buddying, so people from East London going and having a look at what Tees Eskin Wear Valleys were doing, how were they doing it, partnering, the finance director from one place with the finance director from another place to get them to sort of talk about it and share their concerns with each other, but help each other to understand how quality improvement might be actually the helpful way forward. Organisational backing is absolutely key, because it's about changing how the whole organisation sees quality. So what did we find? So we found that quality improvement and rolling it out as this routine way of working, it was about leading differently. It's the signals that are sent to staff about quality improvement, what it means, why they're doing it. So it's demonstrating that commitment to it. Keeping quality improvement, the theme, the topic, really present at board level discussions. And it's also about connecting better and differently with staff at board levels to really understand what their views are on what are the quality issues in that area that you're working in, and what do you suggest is a solution. What it involved leaders doing was letting go of a certain degree of control, giving people the time, the space, and particularly the skills to do quality improvement systematically. It was also about building enthusiasm amongst staff, really getting them involved. And I just want to read a couple of nice quotes from two of our case study sites. This one is from East London. Quality improvement starts with curiosity and a conversation. Start by asking staff, what matters to you and your patients? What do you do on a daily basis that doesn't add any value? And then give the staff the permission to stop doing it. And this quote from Tees Eskin Wear Valleys. It's being given permission for what you know in your heart of hearts is right. It's being given the permission and the support to deliver on that. What we also noticed about the leaders was this transparency, about the need for improvement when it's spotted. So it's using data, what Chris mentioned earlier, it's using the data to understand what the quality issues are, where are they, what can be learned from them, what's the scope to apply some quality improvement methods. It's not about apportioning individual blame. We also noticed that leaders were holding each other to account for what they were doing to support quality improvement, to help realise it, to make it a reality. So when it comes to their individual appraisals or a board level appraisal, they were asking each other questions about what they were doing that was supporting the strategic aims around quality improvement. They were quite brave, we thought. They trusted others, and they were at times going to have to be uncomfortable with the uncertainties that comes with doing iterative change. And so I appreciate this is a bit like preaching to the converted in this crowd, but I think there were some important messages that we took away from this research that I think apply more to the crowd where, you know, we don't have time, or what is this? What does Kaizen mean? What is all this sort of mysterious terminology? So maybe we're speaking more to the people who have not yet been convinced. So what we concluded was that quality improvement can make a difference. In those sites, they had reduced waiting times, so critically important for someone experiencing a mental health crisis to know that they will get the support in a timely way. And the sites really worked hard to reduce those waiting times across services that were ward-based and ones in the community too. Quality improvement also led to wards feeling like a safer place to work. There were reduced incidents of violence on wards, and you know, this in turn, this has knock-on effects on, you know, staff absenteeism and people just not wanting to work there anymore, basically. They all three sites actually had developed new services to help people in their recovery, and moreover, they had really changed the organisation, how it felt to work there, the culture. They really improved how engaged staff felt in the work that they were doing. So we also found that quality improvement takes time. This wasn't just a matter of months to convince each other that this was the right thing to do. Actually, these stories were decades in the making. It's a continuous process, it's not a one-off, and it can't be treated as we will just do this quality improvement project here and that will fix that thing. This was about taking a much broader view. Quality improvement, it requires fidelity to the method. It's not seeing it as a fad. It's really taking on board what that method is telling you and really sticking to it. And quality improvement in mental health, actually we found it's broadly the same as in other settings. We found that it doesn't, so one concern was, you couldn't really do quality improvement in sort of out of hospital setting, you couldn't do in community services, it just wouldn't work. Well, our sites found that it could. They can still get their staff engaged and apply the same types of techniques, regardless of where sort of staff physically worked. But one possible area of difference could be about using quality improvement methods in co-production with service users and carers. Arguably, the mental health sector has a longer history of working with service users and their carers in the process of aiding their recovery, but this also seemed to move across to drawing them into quality improvement as well. And so I'm going to end with a plug for a breakout session just after the break, which will be about working collaboratively with patient service users, carers, to improve quality.
Shilpa, thank you very much.